Good afternoon, everybody. So my talk was the last talk before lunch. So I was going to cut it short, but now you have no option but to listen to me fully. And so I just began. I will talk about neurological complications of cancer therapy. So as you know, I'm a medical oncologist, and this is how the flow will go on. It will be first the nervous system complications from radiation therapy, from chemotherapy, and the last will be the biological agents. Why radiation therapy first? Since I'm a medical oncologist, I'd like to point out others' problems first. So I would go on with the radiation therapy complications. We'll just divide it into three parts: the CNS complication, the spinal cord injury, and the peripheral nerve involvement. CNS complications, it will be a combination of vascular damage and damage to the glia, oligodendrogliosides being the most important one. We can divide it into early injury, early delayed, and the late injury. The difference being, early injury is usually because of vascular injury and resulting edema. It usually will be characterized by nausea, headaches, and is very steroid responsive. The early delayed injury will be from 1 month to approximately 6 months. It will be characterized by drowsiness, fatigue, cognitive problems. MRI in this case may conversely show a tumor progression type of picture. They are reversible usually. Improvements may be hastened by steroids. Excuse me. Late injury is an irreversible, permanent, diffuse white matter changes. This is also called as leukoencephalopathy. I'll touch upon this again and again and again in other topics also. Focal areas of necrosis and cognitive impairment depends on age, radiation dose, the brain volume, and a combination with chemotherapy. So basically, late injury is the irreversible part. If you talk about the spinal injury, again, almost a similar picture. There's no acute, but there's an early delayed and a late delayed. The early delayed part will be mostly reversible, develops at a median of 3 months, and depends on RT dose, and usual treatment is not necessary. The late delayed is irreversible in most cases, and patient usually present with weakness and sensory loss, and examination may reveal a sensory level. And anticoagulation and hyperbaric oxygens have been used, but benefit is mostly seen only with corticosteroids. If at all there is to be any benefit, usually there is no benefit in any therapy. How does peripheral nerve either plexus or peripheral nerve get involved? If you can see, the brachial plexus is commonly implicated in breast and lung radiation. Lumbosacral plexus obviously in pelvic tumor irradiation. It is similar to something like spinal cord early delayed and late delayed varieties. Only thing is it is the nerve and the nerve plexus which is involved. But we need an EMG and an NCS between late delayed types and nerve damage due to plexus and nerve involvement by tumor recurrences and infiltration, which sometimes becomes very difficult to differentiate between the two. That is a tumor recurrence and nerve involvement because of infiltration versus radiation damage. Treatment includes steroids, pain management combined with physiotherapy. Coming down to our part, the chemotherapy and biological therapy induced neurological complication. There will be a great session on CIPN, that is chemotherapy induced peripheral neuropathy. I'll just touch on it very briefly. Most of it will be the other implications. So I'll just divide it into three parts again. Chemotherapy with complications because of platinum-based therapy, non-platinum-based therapy, and with biological agents. This I found very useful because most of the time we write grade 2 peripheral neuropathy without knowing what does exactly grade 2 mean or grade 3 mean. So the NCI CTCAE says the grade 1 is asymptomatic clinical or diagnostic observation only. So it is the most important thing is it is asymptomatic. So the minute it becomes symptomatic, you should put it in grade 2. That is moderate symptoms limiting instrumental ADL, severe symptoms limiting is a self-care ADL, that is grade 3, and obviously grade 4 and something which is very rarely seen. But what is instrumental ADL and self-care ADL? So instrumental ADL stands for preparing meals, shopping, using telephone, managing money, and self-care ADLs including bathing, dressing, undressing, using the toilet, taking medications, and not bedridden. So there is a subtle difference between grade 2, grade 3, and grade 4, but we need to make it out and grade our toxicities properly. Something which I come to understand now after all this time. what are the risk factors when we talk of any neurological complications because of chemotherapy? So it will depend on the dose intensity, the length of treatment, concurrent administration of other neurological agents, especially platinum derivatives, age, something like in bortezomib, it will depend on the route of administration. The genetic makeup may also be a significant risk factor which we usually ignore. So I know we have started doing it, we do the DPT levels, and it can help detect severe neurotoxicity as well as other toxicities as in cases of 5FU infusion. Association has also been reported between inherent polymorphism in the CEP27 gene, which encodes a centrosomal protein involved in microtubule formation and incidence of vincristine-related neuropathy in children. And there is a link between inherent variation in Charcot-Marie-Tooth gene and susceptibility to paclitaxel-related neuropathy. Just so that we know, we should have a proper history just before we start any chemotherapy regimen, because I'll come to it, every single chemotherapy regimen can have some or other neurological implications, can have some or other neurological toxicities. We can just limit it, make it lessen, by taking a history properly and knowing the risk factors properly as well as the genetic risk factors. Platinum-based chemotherapy, obviously cisplatin comes into the major picture. Its range of neurotoxicity includes peripheral neuropathy, ototoxicity, vestibulopathy, and encephalopathy. Peripheral neuropathy, it is usually symmetrical, predominant sensory peripheral neuropathy, usually develops when the dose reaches somewhere around 300 milligram per meter square. Remember, if we are giving 3 weekly cisplatin in a head and neck patient, we reach 300 milligram per meter square. And the implications come at a later date when we have finished therapy. Axonal neuropathy that predominantly affects large myelinated sensory fibers and dorsal root ganglion is the primary site of damage. I'll not again dwell much into it because we have a dedicated talk on this, but I like to stress on the ototoxicity. It is characterized by dose-dependent high-frequency sensory neural hearing loss. So we should always have a baseline PTA, that is pure tone audiometry, before we start cisplatin. Bilateral, irreversible, often accompanied by tinnitus, vertigo. It becomes very symptomatic and limits the ADL in a patient which has developed this. Carboplatin is much less ototoxic than cisplatin, and oxaliplatin is the least. Concurrent administration of cisplatin and RT results in synergistic ototoxicity, especially in the high-frequency speech range. Ototoxicity can be particularly severe in children. Cofactors contributing to neurotoxicity includes younger age, particularly less than 5 years, use of cranial radiation, diagnosis of a CNS tumor, diminished renal function, high cumulative doses of platinum compounds. So what do we do? To minimize cisplatin-induced ototoxicity, the best strategy till now has been monitoring and early detection. Pharmacological agents, sodium thiosulfate is the one which has been tested the most. It has proven effective. There are 2 large trials. The Children's Oncology is the COG trial and the SIOP EL6 trial, which demonstrated significantly lower incidence of ototoxicity without compromising efficacy. Both of these trials had somewhere around 100 and 130 patients. They have demonstrated efficaciousness, but this is limited to children again. Amifostin, vitamin E, and intratympanic dexamethasone have all been tried. Intratympanic dexamethasone has shown benefit, but again, it is just an early phase 2 trial, and data is really insufficient to recommend its regular usage. Encephalopathy, we usually don't think of it, but it is present, rare, observed mostly seen after intraarterial administration. Usually we don't do it now. Symptoms include seizures, focal neurological symptoms, including cortical blindness. Associated with reversible abnormalities in the white matter, that is reversible posterior leukoencephalopathy. And cisplatin-induced encephalopathy must be distinguished from metabolic. This is the reason I'm talking about this. It must be distinguished from metabolic causes, including water intoxication caused by prehydration, treatment-induced renal impairment, hypomagnesemia, hypocalcemia, and SIADH, all of which are commonly seen even with a weekly doses of cisplatin. Okay, I'll require 2-3 more minutes. Carboplatin, again, I'll not go into peripheral neuropathy much. Carboplatin is less ototoxic, but again, in children, carboplatin can also be severely ototoxic. There's something called as microangiopathic hemolytic anemia and in progressive neurological impairment and death. reversible posterior leukoencephalopathy syndrome, and renal toxicity followed by intraarterial administration for brain tumors, which was practiced but recently has gone out of trend. Oxaliplatin, why again would I talk about it? It is very, all of us know about the peripheral neuropathy part of oxaliplatin, but the acute neurotoxicity, in 2 reports it says more than 85% experience symptoms of acute neurotoxicity. Typical symptoms will include difficulty swallowing cold items, throat discomfort, sensitivity to touching cold items, paresthesias, dysesthesias of the hands, feet, and perioral lesion, muscle cramp. In addition to muscle cramp, other motor symptoms may include jaw tightness, voice changes, ptosis, rarely priapism. More commonly at doses of 130 mg per meter square, that is our Kepox doses, than at 85 mg per meter square, and are infusion rate dependent. It is thought to result from chelation of calcium by oxalate, a metabolite of oxaliplatin, with transient activation of disinhibited peripheral nerve channels, and causing hyperexcitability of the peripheral nerves. Increasing the duration of infusion from 2 to 6 hours during subsequent treatment has been reported to diminish the incidence, particularly the pseudolaryngosperm, which is very painful and very scary to the patient also. We just increase the duration of infusion and the patient benefits. The reason why I'm telling you again about this is cumulative sensory neuropathy does develop. So if you have acute neurotoxicity, you have higher incidence of developing subsequently cumulative sensory neuropathy. And the oxaliplatin neuropathy may continue to worsen for a few months after treatment. This phenomenon is called coasting, and it is, the ones who serve would also know, but it is very commonly seen when we are somebody who has been getting oxaliplatin especially for the 6 months time. I'll just skip the symptoms. Non-platinum cancer chemotherapy. I'll just talk about one thing, methotrexate, again because rest of it mostly will be covered in the CIPN. Methotrexate, we have used it for n number of reasons, but can cause acute, subacute, and long-term neurotoxicity. It can manifest as aseptic meningitis, transverse myelopathy, acute and subacute encephalopathy, leukoencephalopathy, and manifestations of MTX neurotoxicity are largely determined by its dose and route of administration. I'll talk about particularly IT methotrexate, which we commonly give for so many malignancies. And IT administration is rarely associated with posterior reversible leukoencephalopathy syndrome, seizures, subacute focal neurological deficit, lumbosacral polyradiculopathy, non-cardiogenic pulmonary edema, pneumonitis, and sudden death. So next time we give IT MTX, you should all be really scared. I got scared after reading all this. And leukoencephalopathy is a delayed complication of IT MTX, usually occurring 6 months after therapy and when the cumulative dose of MTX exceeds 140 mg. There's no standard treatment for acute and subacute toxicities, but there is an accidental overdosage of IT-MTX. Recently in ICON, there was a presentation on accidental dosage of 500 mg of IT-MTX. I thought, how is that possible? But if you really see the 500 mg vial and the 15 mg vial, if you don't really read the dosage, you can give the 500 mg vial, especially if that is kept in the theater. And patients with such overdoses are treated with combination of intrathecal administration of glucorapidase to metabolize the methotrexate, rapid CSF drainage by lumbar puncture, CSF exchange, ventricular lumbar perfusion to reduce the amount of methotrexate in the CSF, systemic leucovorin rescue, plus alkaline diuresis. So next time before IT-MTX, please see the vial again. I'll not talk about the other agents much because all of them are usually chemotherapy-induced peripheral neuropathy, and they have been mentioned. Just a minute or two about neurological complication of treatment with biological agents. So the types of biological agents which we right now use are biological response modifiers, monoclonal antibodies, and CAR T-cell therapy. Interferons, largely outdated, nobody uses now, but still used most. But the reason why I'm again bringing interferon is almost, just see the amount of toxicities they have. Almost some or the other will develop a toxicity, approximately 50%. And we usually don't consider all this: depression, anxiety, irritability, emotional lability, somnolence, paresthesias, dizziness. But all these can be possibly induced by interferon administration. Interleukin, usually used in combination with interferon, particularly in RCC and melanoma, used to be now. Neuropsychiatric complications occurs in approximately 30 to 50% of the patient. TNF alpha, again, really not much used, but can induce encephalopathy, transient aphasias, and other focal deficits. Monoclonal antibodies, we use rituximab left, right, center without really thinking that cases of progressive multifocal leukoencephalopathy have been caused by rituximab, have been reported, including alemtuzumab, which I'm sure nobody much uses now, but still rituximab which we use significantly. Trastuzumab experience headache, dizziness, insomnia, but think about TDM1. It is associated with increased risk of CNS, radiation necrosis, cerebral edema from brain metastasis treated with stereotactic radiosurgery. So if you are planning to use Kadcyla or TDM1 anytime in future, make sure the patient does not undergo SRS, because even in one retrospective analysis of 12 patients, incidence of radiation necrosis was 50% for patient who has received TDM1 during SRS, and 28.6% who were discontinued TDM1 before SRS. I am not sure about the WBRT data, but even that can have an increased incidence of complication, especially since the complication is so severe. Bevacizumab, more of arterial thromboembolic events, optic neuropathy. Brentuximab vedotin is an antibody drug conjugate used for CD30 positive lymphomas. 36 to 69% patients will develop a peripheral neuropathy of any grade, and approximately 4 to 15% will have severe, that is grade 3 to grade 4 neuropathy. So again, when we're using it, just think of that. Immune checkpoint inhibitors, do I really need to talk about it? But the overall incidence of neurological immune-related adverse events in patients treated with ICI is usually low. In a review of 9,200 patients, the incidence was 3.8% with anti-CLA4 and 6.1% with anti-PD-L1 and 12% with combined both. Most of the reported toxicities are usually mild, with headache, peripheral sensory neuropathy being the most common. Serious neurological implications include sensory and motor neuropathy, GBS, myasthenia gravis, encephalitis, aseptic meningitis, transverse myelitis, lymphocytic hypophysitis causing hypopituitarism. The time of onset typically varies, but develops within 3 months of starting ICI therapy, usually. Just the last stop. The CAR T-cell therapy. CAR T-cell therapy, patients' T cells are collected and blood and modified from blood and modified to express a CAR antigen, followed by ex vivo expansion and then reinfusion back into the patient. So cytokine release syndrome is the most common implication and the complication. But there's something called a cytokine release encephalopathy syndrome, or CRES, or immune effector cell associated neurotoxic syndrome. Both of these have, and both of these are very common events, and they have high incidence of residual neurotoxicity. And in case series of patients treated with CAR T cell therapy, 40 to 62% of the patients develop at least one neurological adverse event, presenting usually only within 4 to 5 days after CAR T infusion and lasting for 5 to 11 days. But again, the reversal is not usually complete. So there is some residual neurodeficit. And this is the last slide. Thank you. The reason I'm telling about all this is every time when we begin a chemotherapy, we all look at CBC, we all look at RFT, LFT, but we forget to assess the neurological toxicities. So next time we see a patient, next time we are giving an IT MTX, next time we are advising any sort of therapy, just remember there are some neurological implications to every therapy, including rituximab, which we never thought had any neurological implication. Thank you.